Hello and welcome to Maternal Mental Health Leadership Alliance's webinar on paternal mental health. We just opened up the webinar gates, and so people are flooding in, and so we'll just give a minute or two to allow everybody to join the room. And good afternoon to everybody who's joining us. I'm Adrienne Griffin. I'm the Executive Director of Maternal Mental Health Leadership Alliance. And welcome. We are so glad that you're with us today to talk about paternal mental health. We appreciate you taking time from your busy schedules, especially as we are heading into summer. So just grateful that you are here with us today. And we are just going to get started. So next slide, please. So just a few housekeeping things. At the bottom of your screen, you will see the Q&A button to go ahead and put in a question. You can also use the show captions button to see the live captions and use the reactions button to share your emoji. We saw a couple of clapping hands going up already. So grateful to see that. Next slide, please. So again, I'm Adrienne Griffin. I am the Executive Director of Maternal Mental Health Leadership Alliance. We are a small but mighty nonprofit organization dedicated to improving the mental health of mothers and other childbearing people in the United States. And we focus on policy and health equity. And we have three strategic pillars. We advocate for change, we build partnerships, and we curate information for the field of maternal mental health. And so this webinar today squarely fits in that curating information. And we are always so excited to share information with the field about the latest information on any specific topic. And today it's on dads and depression and their mental health. Next slide, please. So in this webinar today, we'll provide an overview of paternal mental health. We have a dad who will share his lived experience. We also have psychologists and psychiatrists who will share their clinical perspectives, and we'll also be uplifting programs and resources to support dads and their families. Next slide. And very exciting, we have a new fact sheet that we just released last week. Our paternal mental health fact sheet, we used to call it Dads and Depression, but we know it's so much more than depression. Just like with moms, we're trying to move past postpartum depression to be more inclusive. And we will email you that new fact sheet after this webinar. Next slide, we will also send you an email with a brief survey, the presentation slides, the webinar recording, and this new fact sheet that we just produced. So keep an eye out for that at the end of this webinar. Next slide. And as with all of the topics that we address, some of this information can be challenging, right? We're talking about mental health. Sometimes, this may bring up, just your feelings from the past. And so just take a break as needed. You can always come back to us. Again, we will post all of this information on our website. You can download recordings afterwards. And so we're grateful that you're with us here today, but certainly understand if you need to step aside. And next slide. So I am so thrilled and honored to be welcoming, we call them the dream team of dads, with us today to talk about paternal mental health. Sheehan Fisher, who is a clinical psychologist at Northwestern University, Illinois, also the dad to a lovely 5-year-old daughter. David Levine, who is a pediatrician in New Jersey. He's going to be talking about his lived experience. And he will also be the next chair of the board of Postpartum Support International, which is terrific. And then Danny Singley, who keeps us all laughing. He's a clinical psychologist, also a part-time stand-up comedian. I'm just joking about that, but maybe you are. I don't know. He keeps us all laughing. And he also is on the President's Advisory Board at Postpartum Support International. And so we're so thrilled to welcome all three of you here today. Welcome, gentlemen. And I'm going to pass the microphone off to Sheehan. Next slide, please, who is going to give us the lay of the land with overview and research. And Dr. Fisher, the microphone is all yours. Welcome.
Thank you for having me. Really enjoyed to be here and appreciate all the work you all do to support mom's mental health, but also being willing to include topics on fathers' mental health. So as mentioned, I'm a perinatal clinical psychologist. Actually, my work is a lot on mothers and fathers, even though I'm known as a father specialist. A lot of my work and research has been looking at both parents. Next slide, please. So when we're talking about perinatal mental health, I think it's really important to think about the risk factors for depression and fathers. And this is important because some of them and many of them are similar to moms, but there are some unique experiences that parents go through, specifically for being a father. When you're transitioning to becoming a parent, it's a life transition. And that's something we don't always think about because it looks like a positive thing. I'm going to become a new parent, such a great thing. But any role transition comes with a lot of stress, even a positive one. I even encourage many of my patients, please don't have a new baby, get married, and buy a new house all in the same year. Like there's just a lot of change, although all positive, it can have a huge impact. So for fathers becoming a new parent, they're trying to adjust to, which is, they known as the impossible, the work, family, personal life balance. How do I do all these things at once and manage it? And uniquely for fathers, they are going through this new experience without really a blueprint on how to do it. Many times their father was not involved in the home. And so they don't really know, how do I balance working still full time, but also showing up for my family, being an involved parent, being an equal parent in the home, and also have time for relaxation or have time for friends or even time with my partner. So this is quite of a difficult transition for them to go through. They are also, of course, at risk for reduced social support because they're focused obviously on their family. They don't necessarily have the friend network or the other family members that can support them in the same way. And that means that their normal way of coping with life stress is being decreased. Even just adjusting to becoming a parent means you have to have time to be a parent, which many times fathers don't have access to. In general, we need to change our policies around parental leave for even moms that have full leave. We are, for all the industrialized countries, way behind every other country on how to make sure that everyone has fairly supported time to be with their child and have it not just be 3 months, but up to a year or more. But if it comes to paternity leave, most fathers get maybe 2 weeks. Sometimes they get a little bit more depending on the company policy, but not federal policy. And that means fathers don't get a chance to actually adjust to this new role. They're almost immediately ripped away from the family, and therefore that leads to not only disengagement, but also creates a lot of emotional distress because they don't get a chance to actually bond with their child. There's increased financial responsibilities. When I've been involved with father groups, that's something that comes up frequently, that even if, which in most families is the case, that both parents are working, the fathers still feel this social pressure that they must maintain their job, they must provide for their family, and therefore with or another mouth to feed, and think about like college funds and all these things that comes with becoming a new parent, it can be quite stressful thinking about what can I do to take on this responsibility. There's, of course, we see a lot of change in their relationship with the partner, that both parents tend to feel less satisfaction and also have an increase in conflict in their relationship when there's a new baby because everyone's sleep deprived, they're trying to adjust to being a new parent, like just even that role, they're trying to juggle and try to work together, but maybe aren't on the same page. And that can lead to conflict, but also just because they don't have as much time for each other, they might start to feel distance from one another. And we see this even impacting their sex life, that even after the first 6 weeks postpartum, after the mom is cleared, either the mother or father or both aren't necessarily as interested in sex because of the stress they're dealing with, which means, once again, a lack of opportunity for connection. Fathers do even talk about feeling that they're positioned as a secondary parent, that they didn't ask for this, but just based on the gender title, they're automatically considered as a secondary parent. I always allude to the fact that when we use the terms mother, father, we're just using euphemisms for primary parent, secondary parent. And that isn't necessarily what the family wants, but they feel pigeonholed to that position. And therefore, their father sometimes feels that their opinions, their approach is devalued within the home, not only necessarily from their partner, but it could be from in-laws, from their own family, from society in general, even from the medical system, that they are viewed as not as an involved parent, even if they tried to be. Something that is interesting because fathers and many times men are not really trained at an early age to think about what it's like to be a parent. They have unreasonable expectations sometimes about what they expect before the baby comes versus what they actually experience postpartum. So sometimes I've worked with fathers where they say, "Oh, I can't wait to throw ball at the baby." I'm like, "Well, that's going to be a few years from now. Like the first phase is going to look like that. Their expectations are not matching what their actual experience is going to be." So they have to actually start to learn about what to expect. What is it like during the first month? What is it like up to 3 months? Like really what that developmental stage of this child, and what is their role during that developmental stage so that they don't feel blindsided by this new experience. And this is just talking about things when it comes to like a normal birthing experience, but there's obviously complications that can occur, and that can be actually pretty impactful for the father of feeling, threatened or worried about the mother's safety, the child's safety, or the child's well-being or mobility. So there's a lot that comes into the experience that can also have an impact on their stress. We historically did not think about fathers having hormonal changes, but that is actually relevant, that they actually do go through hormonal changes. We're learning that they have a decrease in testosterone during the postpartum period as they get more involved, and that's being associated with depression symptoms. And then finally, the mental health history of themselves and their partner is relevant. So all these things come together to have a risk for the fathers developing depression that is not just out of the blue. From biological to environmental, they are at risk of developing depressive symptoms. So next slide, please.
Yeah, so Sheehan, as you're going to the next slide, I just want to chime in there about, but the very first thing you said about like, don't get married, have a child, buy a new house, switch jobs all at the same time, right? And then we also layer on top that we're also starting to think about caring for our parents as well. So like the childbearing years often, interact with like the prime work years and, caring for parents. So there's a lot that are, parents are taking on at this time. So I'm just so glad that you started with that. Like just sort of the things that we think are normal, are huge stressors. So thank you.
I appreciate you saying that. I was add on a little bit. It's just that historically people had children earlier, but because we're having children later, you're right. The parents are a little bit older. You're at the peak of your career, and mothers and fathers are going through all this at the same time. And therefore, it's a new transition for us about how do we adjust to all these different pressure points, including being in America, we bounce around the country. So we're not even close to family for support and things like that.
Exactly.
Yes. So for fathers, we noticed that the ratio is about 2 to 1, that mothers have about 20% of depression during the postpartum period, fathers about 10%. And the peak of this is around 3 to 6 months postpartum. And we have traditional measures of depression, like the PH29. You see that a lot in hospital settings, or people also use the depression inventory or the inventory of depressive symptomatology. These are commonly used for depression in general, but of course, commonly known as the EPDS is used for depression and it's been validated in mothers and fathers. It's been validated around the world. It's a well-validated measure for perinatal depression. Next slide, please. And it's for 3 to 6 months for paternal depression specifically. Unfortunately, sometimes though, we don't always have access to the father. So one of the concerns around this is that when the father is not at the prenatal visit or postpartum visit, we don't have access to the information about depression. So I developed a measure a few years ago for adapting the EPDS to be a partner report so that the mother can report on the father's symptoms of depression, and then if necessary, do a follow-up with the father if the mother screened him high to actually get direct report of the father. And it was shown that the mother's report was a valid and reliable measure of father depression. So this is a way to kind of circumvent some of the limitations of the maternal child healthcare system, even though we need to do more of inclusion of fathers and encourage them to be involved. If we don't have access to them, this is a way to screen for their depression. Next slide, please.
And I just want to chime in here. I like looking at the things in the chat and picking up on something that you said, Sheehan, that right, the peak onset of paternal depression is 3 to 6 months postpartum. And I know a male pediatrician in Richmond. His name is Walter Chun, and he requires both parents come in for the 4-month well baby visit, and he screens both of them and says also like to the first parent, how is the second parent doing? And then asks the second parent how you're doing, and then vice versa. And so he makes sure he's checking in on them as well as having them check in on each other, which I just thought was really a unique way of handling that.
I appreciate that. And actually, I have a whole protocol for training parents before they become parents about many different things of the adjustment of that role transition, but also specifically how to be able to look out for signs in your partner, because people are not always aware of their own experience, but your partner knows you well. They know those nuances that are different and can actually report that to either the doctor or even to your partner. But one of the concerns that we have, though, is that fathers and men in general may manifest depression differently. Think about the cultural aspect of depression. We see this within racial and ethnic studies. The same thing applies around masculine culture. Men tend to underreport symptoms. There's a clinician bias against diagnosing depression in men. And also men might have a cultural interpretation of their experience that is different than traditional measures. So there's a concept called masculine depression, which actually starts to encompass the broad experience of fathers and men when they're dealing with depression. And it gets into including externalizing symptoms that in our society is more susceptible for a man to engage in aggression, hypersexuality, and drinking than it would be for a man to cry. So men might manifest the depression differently through externalizing it versus the internalizing or emotional symptoms. And then also looking at masculine depression, even for the internalizing emotional symptoms, wording them a little bit differently to make sure that it's actually something that includes how fathers might be more comfortable reporting their symptoms that doesn't contradict maybe the way that the masculine culture has trained them. Next slide, please. So there's been a study at JAMA that was across men in general that really helps to highlight this point. We know that in men and women, the ratio is that 2 to 1. We see it in men and women in general, we see it postpartum. But once we add in masculine depression symptoms, that ratio disappears. When we actually understand depression from the experience of men, we see that the ratio is about 1 to 1, that both men and women are at equal risk of developing depression. And we need to replicate this within the perinatal field to understand, is that ratio 20% to 10% accurate, or is it just that we're asking the wrong questions when we're assessing for depression? So we need to really rethink this when we think about for the research and the screening. Next slide, please. And this is just a brief sample of one version of the masculine depression called the masculine depression scale. And you can see how the wording for the internalized symptoms look a little bit different about that might be more culturally acceptable for men to report. And then also inclusion of externalizing symptoms, like I mentioned, of aggression or hypersexuality or substance use as a way to cope with their emotional experience. What I want to work on and actually think about writing a grant on right now is actually to do a short form this that can actually be done in a screening process to actually be able to assess the father's experience in a way that would actually get more accurate data on the rates of depression in men. Next slide, please. So I just want to also briefly highlight there are other cultural considerations we need to take into account. That we need to understand that when I listed out those stressors, those are the stressors across the board for many fathers, but the BIPOC fathers might experience very unique race-based stressors. And that also goes along with their access to healthcare, that they may, even if they're going through different distressors for their medical and mental health, they have less access and resources available to them because of the disparities that exist in the United States. And there's a lot of stigmatization within the culture about mental health because of the history and the relationships with the medical system across many different race and ethnic backgrounds. And that needs to take into account why they may be hesitant to acknowledge or even report their symptoms because of how it might be used against them. On the clinician side, though, there's also clinician bias, that clinicians have a race-based bias toward diagnosing it as antisocial personality or other things. As a quick highlight, we know that for the diagnosis of antisocial personality disorder is supposed to be like more of an inherent biological disorder. But the fact is that when you look in the prison system, there's a high rate of diagnosed antisocial personality disorder, but that's also a system that has a disproportionate rate of Black men in the hospital system, in the prison system. So the idea is that we're basically saying that Black men are inherently antisocial personality disordered, but in actuality, it's a social construct. So we sometimes, even the medical field, don't always understand the bias that is built into how we diagnose versus understanding the breadth of it, and even that this might be depression or other ways of understanding the symptoms. So there is a clinician bias, but I also want to highlight that there's a stigmatization, the view that Black men are not involved in the home. And this is against research. Like the CDC showed that Black men are the most involved fathers of all fathers in the United States. And yet they're still stigmatized as the least involved fathers. So this is something that we have to be aware of how we understand them and engage with them, because that will lead to disengagement from the medical system. And then last slide, thank you.
And you're getting lots of love on that one there, Sheehan. Yeah.
That's good to see, thank you. And then I also want to highlight, even though we're talking about fathers, the next step within perinatal mental health is get away from the heteronormative experience. We have a heteronormative perspective of the family. Mother, father. Like it took a long time for us to even talk about fathers. But the thing is, we need to expand beyond this network because there's a lot of other families. And I did a talk recently about, I think the next generation, about 20% will be coming from sexual gender minority families, which means if we only do research on heteronormative families, we will not be able to support properly these other families that exist now, but will be growing in the future. So we need to be inclusive of sexual gender minority families, understand it from their perspective, and design studies that are culturally sensitive to this particular population. Because once again, the risk factors for depression are going to look different. They are actually more criminalized and even in the medical system not supported in the same way as heterosexual families. And therefore, we need to be able to understand that differently along with our assessment and also even our intervention. So there's a lot that we can do to support these families. Thank you.
Thank you so much, Sheehan. So a couple of quick comments from the chat before we move on. See Daisley said that she works in a NICU and she's always shocked when dad scores higher than the mom. I'm so grateful, Daisy, that you're screening parents in the NICU. We know those parents are at super high risk of experiencing anxiety in particular because of all of the stress that goes with having a baby in the NICU. And I really love, Sheehan, how you started off again with, it is just stressful becoming a parent, right? If we just acknowledge that it is stressful to have a new baby in the household, that's sort of like opens up like the conversation, right? I mean, it is challenging to have a new baby in a household, no matter if that baby is a good sleeper or not, right? Everybody's schedule is off. There is a new person who is in charge who can't tell you what he or she needs, right? It's challenging. And so then we can, like, it sort of lets the steam out a little bit, and then you can like dig into some of this stuff a little bit more. So anyway, great presentation. So thrilled. Thank you. There was one quick question that I think I want to ask before we move on, which is somebody asked, what do you do about when you screen the dad? Like, who's supposed to follow up?
So that is part of the thing. When you screen, you should have a place to send them. Like, otherwise, it's almost unethical to do it. Right. So that is the piece of it. And that's what's difficult sometimes in the OB-GYN clinic versus the pediatrician clinic is how do we make sure that if we get a screen, where to send them to make sure that someone is following up with them rather than the kind of dropping off. And
Absolutely.
even, something about even what measures to use, because if you screen for the suicidality, that makes you liable. There's a lot of different considerations that play into that picture. So it's a bigger conversation, but important.
Yeah, thank you. And so we do want to put out that the one resource that is free, that is available to anybody, mother, father, is the National Maternal Mental Health Hotline. And we'll put the number in the chat. It's 1-833-TLC-MAMA. And any parent can call and talk in real time. It's phone or chat real time with hotline counselors who are trained in these issues. So there is always a resource that's available. So awesome. Thank you so much, Sheehan. We're going to shift gears here now. And we are going to introduce Dr. David Levine, who, as I mentioned earlier, is a pediatrician and a dad. Go ahead, next slide, please. Is a pediatrician and a dad, and quite unfortunately is also suffering from COVID like right now as we speak. So we're glad that he's with us today, and just so grateful to you, David, for taking time to be with us, dragging yourself out of your sick bed to help raise awareness about these issues. So I'll turn it over to you.
Thank you very much. I appreciate it. I think this is a good segue from what Dr. Fisher was saying. And honestly, I kind of wish I knew all of those things 10 years ago when I became a father for the first time. It's remarkable how little you know, and then you experience it and you think, this is the weirdest thing. No one could possibly know what I'm going through. And then you hear something like Dr. Fisher just said, and you realize this is so much more universal than you could ever imagine. And I hope that what comes out of today is not only do all the people that are here have a greater understanding of this, but you get this information out to others, because what stops so many parents, so many fathers from getting help is they don't know what they're going through. And I did not know either. So I'll take you back 10 years ago. So I'm a general pediatrician, I should say. I'm the head of ambulatory pediatrics at Atlantic Health System in New Jersey, and I'm the current vice chair of the board of PSI, Postpartum Support International, which I'll throw in there that www.postpartum.net has a whole section on fathers, and also a lot of links and numbers that people can call. So just to, I know I'll get back to it, but like what the question to Dr. Sheehan was, well, what do you do if you screen somebody? Well, that was always the biggest concern as a pediatrician. In the state of New Jersey, we were required to screen mothers. But the whole question was, well, but what do you do? Like, none of us had the slightest idea who we could send to, because what are you going to do? You find somebody and then suddenly the parent is your responsibility. I'm a pediatrician. I'm not the parent's doctor. But there are so many people, there's so many more outlets out there today than there were 10 years ago when I went through this. So when my first was born, my son was born 10 and a half years ago. I had no prior history of any mental health issues, and I was very eager and very excited for his birth. But after a couple of days, I began to feel very odd, to the point where probably within the first week or two, I Googled fathers and postpartum depression. Um, as a pediatrician, I knew what postpartum depression was. I just had no clue that a father could experience it. I believe I found one article called "Sad Dads," and it gave a lot of information, but it was the only thing that I could find. And then I stayed home because I took 2 weeks off for on vacation to be with my wife and to try to help out at home. So that was weeks 2 and 3 of my son's life. And in the state of New Jersey, you are able to have you're allowed to take parental leave. So I decided I was going to take that, and my wife was going to take 3 months, which is what she received from her work, and I was going to take month number 4. So she'd be home, and then I would be home. So by week 2, 3, when I was home with my wife and my son, I really began to feel very uncomfortable. I was very heightened. I was very stressed. I was very angry. My anger was mostly at my son. I had it in my head that he did not love me and that he was rejecting me. I could not calm him. I had a hard time getting him to settle down. He never seemed to take the bottle as well from me as he did my wife. And I just began to get I just was very uncomfortable. Of course, I said nothing to anybody because why would I do something like that? But I went to his doctor visits. As a pediatrician, I was not my son's pediatrician. I wanted him to see somebody else. I wanted to be dad. And I knew about the Edinburgh, and I actually took the Edinburgh a couple of times during those first 2 to 4 months, and I would get 10s and 11s, but I did it on my own. Like, it's not like somebody handed it to me. I just took my wife's and I just did it in my head. I'm like, okay, that, and I added it up, and I knew what a failing score was, but again, I just did not do anything about it. So I get through those 2 to 3 weeks. I go back to work, and I'm working full time, and I'm trying to be I'm trying to be a full-time parent too at home. I'm trying to take shifts with my wife with feeding and all those things. And I know any woman who's here would say, oh, well, this is what we all go through. And I get it. I get it. A lot of us dads we're not prepared for these things. Like Dr. Fisher said, we don't have a role model for these type of things. So in no way do I mean to sound like, oh, woe was me. It's more, it was something I was going through. I wasn't sleeping enough. I was going to work, and I was getting, people in hindsight would say that I was more sarcastic than normal. I was a little rougher around the edges, but no one would ever suspect anything because I was suffering in a more masculine way. I wasn't outwardly upset. I wasn't crying. I wasn't confiding in anybody. I wasn't doing things that would tip anybody off to how I was feeling inside. Things reached their low point at about 7 weeks of life, where I was pretty actively just, bad mouthing my son to my wife, just how there was something wrong with him. He was going to be the end of our marriage. This was it. This was a mistake. There's something wrong with him. We just haven't found it out yet. I was angry, and my anger was just getting higher and higher and higher. And one day, one weekend, we were supposed to, my parents were supposed to come over. We were living in an apartment in Jersey City at the time, and they were supposed to come over so my wife and I could run an errand, maybe go to lunch and go to a movie. And I was leaving to go to work on a rainy day, and I called my wife from the car after I must have said something particularly terrible that morning, just to make sure we were still on for that weekend. And I thought I heard her say no in the car, and I lost it. I couldn't hold it any longer, and I just started hysterically crying. She started crying. She's like, "What's the matter?" And I said, "I knew it. I knew it. This is it. This is the end of our marriage." And she's like, I didn't say that. I didn't say no. I said yes." And I couldn't stop crying. And she said, you need to get some help. And I said, we need a baby nurse. So luckily at the time I worked for a multi-specialty group that had behavioral health. And there was somebody there who dealt with postpartum depression, not with dads, just said postpartum depression. I had looked things up, like there's hospitals around my area that would have groups for moms. It would always be for moms. And I felt like I would be very out of place if I showed up there, not because my wife was going through something, which she wasn't, but for myself. So I stayed away. Plus, they were during my work hours. So how could I even go anyway? So long story short, I was able to get into a therapist. We were able to get a baby nurse, which at least they let me get some sleep. And I started to work with somebody. That's not to say that everything got better, but I was able. But I was very, very worried about my time with my son. Like that fourth month was coming, and in my current state of mind, there was a chance that something very terrible would have happened during those 4 weeks that I was alone with him. I would say to parents later on that in that moment, I understood why. I understood how abuse and these traumas can happen when you're just at your breaking point. If you don't know what else you can do and you just lash out and you make a terrible mistake. I never in my life ever figured like how somebody would ever hurt a child, until I realized how close I probably came to doing so. And I never laid a hand on him. In my brain, I did. In my mind, I did. But I never physically did anything. So I was able to start to get help. I was able to get some sleep. I even took my son to a couple of my therapy sessions. And things did get better. They were bad enough, though, that as Dr. Sheehan said, sometimes you do a lot of stressful things all at once. In about a 15-month span, I got a new job. We got married. And then we had a baby, and then about 6 months after he was born, we moved. By the time we moved, I was getting better, but at our second anniversary dinner with my wife, she cried pretty much the entire time because because I had just made made a mockery of our second year of marriage, which basically was my son's first year of life. Because at that time, my wife had no idea. I never told her anything. She just thought that she didn't have the slightest idea what I was even going through. And it wasn't until my son was about 2 that I was going to talk about my experience on an interview on TV. And I realized if there's any way for me to do this, I had to tell my wife first. So I told her what I experienced, not 100% of everything, but a lot of it. And she started crying. And what she said was, why didn't you tell me? And I said, because I was afraid of what you'd do. And she's like, all I would have given you was a hug. And that's who my wife is. And that's who I knew she was. But at the time, I was so wrapped up in here that I couldn't bring myself to believe that. And so I kept it from her. And, I got it out and I spoke about it. And she at least felt that some good might come of what I experienced. Somebody asked if I ever thought about taking medication. And I did mention it to my general doctor, who gave me Zoloft. And I didn't take it for more than a week because you could just chalk this up to being a stubborn doctor. I just didn't think I was sick enough to need medication. Which is common. Like, you just don't think you are until you are. Like, I didn't think I was that bad until I broke down crying. And I didn't even realize how bad it was until I did this interview and I was talking with other specialists that were on this panel and realized that I was having homicidal thoughts. And I didn't realize that I just didn't comprehend the dangers that I was wading into. And so I was lucky enough to get through that. I realized that, or I hoped that I got out of it in time to not have a bad relationship with my son, which 10 years later, I would say we have a good relationship. We had a second child 4 years later. We had to go through 2 miscarriages in between. And I was prepared the second time. Like, we had a baby nurse coming. and everything. So I felt like I was prepared, but as many of you know, there's no way to prepare yourself for this, even if you know it's coming. And it hit me again, not as bad the second time. I definitely pulled myself out of it faster and I sought help faster, but it still got me. And I was more upfront with my wife about it, only this time my anger was taken out on her because I blamed her because she knew what happened the first time. So she wanted a second child. So I was like, this is your fault. You put yourself above you put your needs above my needs. And so that wasn't very nice. But I just remember one day just feeling like it takes so much energy to feel this angry and to be this, stressed, that one day I just decided, you know what, I'm sick and tired of feeling sick and tired. And I just said, I'm done. And I apologized to my wife. And we moved on past that. And again, now my daughter is 6 years old and we have a good relationship. And then a couple of years after after a couple of years after my son was born, I started to talk more about it to patients of mine. And now in my group, we screen both parents regardless of gender. We don't care if they're both men, women, grandparents, whoever biological or not, we screen everybody. And I actually believe that I believe that pediatricians have a very direct role in this because we are the only ones who often see the father or even see the other parent. I think it's great that there's a pediatrician in Richmond who requires that both parents be there at 4 months. That is not an easy thing to do because you can't require them to be there. But one of the few visits that they're there is when you grab them. And
Yeah.
I tell parents during the prenatal, or I tell them during those first 2 visits, the 2-day and the 2-week, like, this is a real thing. I tell them briefly about my experience. I give them a heads up that there is a way to get care. There's people around who can help, and that you don't need to suffer in silence. Many are very grateful for that. I will tell you though that I've screened very few men who've actually come out and said it to me, because it's still a stigma. It's still hard to get them to admit to anything that they're feeling negatively.
Yeah.
But I tell them that this is about the family. This is not about you or your spouse or the child. It's about the whole family. Everybody's got to be okay in order for this to work. And that we can all that we can help, and that
Yeah.
I'm going to lend my ear and whatever expertise I can give to them. And one of the things I've even told our nurses in the nursery is, and I think somebody put this in a message, a lot of times the father is just not a part of the conversation. They're sleeping, they don't wake them up, they don't, they're not addressed, they're not even looked at. They're just, the doctor comes in and focuses on the mother and never even looks to the father to talk directly to them. And that is a huge thing. If you start off by telling the non-birth parent that they're secondary, they're going to feel secondary. But if you try to keep things where you're addressing everybody equally, then they're going to feel equal. And hopefully you're going to break down those barriers and get them to try to talk about some of the things that are troubling them or bothering them. And that will make the unit stronger in the long run.
Yeah. Oh, Dr. David, thank you so much for sharing your story. I am 100% sure that you are a better pediatrician for your experience, and that you are helping dads, even though they may not recognize that. So grateful. And what strikes me so much about yours is this anger, right? That we talked about that. Sheehan talked about that men will often, the emotions that they express with their depression is much more that externalizing, the anger, the withdrawing, those kinds of things. We hear about postpartum rage among moms, and it's really, there's so many things that are taboo, but having this rage during this period, this anger, when this is supposed to be the most wonderful time in your life, really is there's a lot of stigma around that. So thank you for giving voice to that.
Yeah, I think just quickly, a lot of it is that, culturally we're kind of lied to. We're just told that it's supposed to be wonderful, and no one's actually just honest about, yes, it is wonderful eventually, but it is really hard at the beginning.
Yeah.
Especially as Dr. Fisher mentioned, we don't live near our families the way that we used to, where we have that unit that comes together to help a family.
Yeah.
And it's important to be upfront. Like it's not like a parent comes into my office and I'm like, guess what, guys, it's going to suck. I tell them like, I'm trying to be honest and say, it is not easy. It's going to be, you're not going to have that kid till about 4 months, that one that smiles and is so happy to see you, and that it's going to take some work. If you've got family around, take that family.
Yeah, absolutely. So I'm going to tell a quick story, and Mia, also ask you to go to the next slide. Parents are not well prepared. So we have a couple of slides in here that show like all of the different words that we hear dads say. They feel inadequate, confused, all of these different things. And then we have another slide that has quotes from dads. And so we're not going to go through all of them, but I want you to know that they're going to be available to you when we send this out. So quick story. There's a couple that lives around the corner from us. It's a mom and dad. Both of them are pediatricians, and they just had their first baby. And so I said to them right before the baby's born, I said, I'm going to give you some free advice. Sleep is the most important thing. Split the night shift, right? After you get through the first couple of weeks, you cannot function on an ongoing basis without uninterrupted sleep. And I saw them a couple of days ago, the baby's now 6 weeks old, and they're like, thank you so much for giving us that advice. And like I said, they're both pediatricians, and they're like, we would never have thought about that by ourselves. And so anyway, we need to do a better job helping all new parents for sure. So thank you again, Dr. David, for sharing your story. And we are now going to switch gears to Dr. Danny and hear from the clinical perspective. Danny works a lot with dads, and so he's going to take it from here and talk about what he sees from his perspective. So off to you.
Thanks, Adrian. Also wanted to really quickly say, related to what Dr. Levine just said, this is a very supportive environment. And clinically, what I want to talk about to begin with has to do with masculinity and sort of that aspect of gender that oftentimes the paternal salience or the fatherhood identity sits on. People in the chat here are like, way to be vulnerable, way to be raw, and I 100% agree with that. I want people to also know that in the broader cultural frame in our society, that Dr. Levine was one of 3 fathers who experienced postpartum depression and then did what I think was a very courageous move in having a video put together that was put out on ATTN, in which he tells an abridged version of his story, as do the other dads. And the vast majority of the comments were really nasty and critical. Man up, you're being and all the words that we call men who aren't being manly. This is toxic masculinity. You're just being lazy, and so forth. And I think it's really important when we think at the broader level that not everyone is able to see fatherhood and experiencing difficulties and the potential trauma that's involved in it for parents of any gender, and normalizing it or validating that, when what we hear from a lot of clinicians and parent educators and across the board is, Dad, your job is to protect, provide, sacrifice. Dad, you need to be there. You need to be the rock, without continuing on to also say, and Dad, you're probably going to need some support yourself. That's the piece that is really missing. And when people pile on and want to shame someone like Dr. Levine that had a very common experience that just isn't that well publicized, it's unfortunately reifying the kind of gender policing that does the number on young boys, that says you can't have mental health difficulties, relationships are for romance, interpersonal needs make you weak, and vulnerability is weakness, and so forth. I just think it's this is kind of a little enclave of people. So there's a kind of, yeah, maybe you haven't thought about this as deeply before, but when you get out there in the trenches, it's a big wide world out there. So just wanted to say that. But yeah, if you would, next slide, please. So as I said, I want to just make a quick mention to, for masculine identified parents and what we're calling, dads and fathers, it is important to factor in how we do that socialization, not just to being a male, but then also the parental chunk of that. And I draw people's attention to what I see as a kind of generation gap that fathers these days, and there are all kinds of different caveats about, countries and geography and socioeconomics and racial ethnic considerations. But generally speaking, fathers these days are expected to be more engaged in pregnancy and birth and postpartum and in their families writ large. However, there's not very much modeling about the fathers of babies. You see it, it's getting better, fathers of kids. However, if you sensitize yourself to how often am I seeing families in which the father is either just kind of in the background or just not factored in or straight up considered to be part of the problem, versus when do I see content that shows fathers that are awesome at soothing and swaddling and baby wearing and seeming competent. And so I talk a lot with patients of our clinic about the sort of insidious messages that we'll get from different kinds of media outlets as well as from other people in our lives. It's a well-established fact that men tend to avoid seeking help. Dr. Levine talked very clearly about his own experience of that. And unfortunately, asking for help means admitting I have a problem I can't solve myself, which flies in the face of traditional male stoicism and rugged independence and so forth. And to speak to this point, these days, masculinity is oftentimes just conflated with a toxic presentation, like masculinity equals toxic, and it doesn't. The reality is we need to embrace complexity, and there are plenty of circumstances in which being tough and aggressive and stoic and independent and so forth is perfectly functional and helpful. However, if you're only that, if you're rigid about only being that sort of Marlboro Man presentation, the statistics show the men are likely to die 5 to 6 years sooner, get more divorce, lower quality of life, more depression, more attempts at suicide, more likely to die by suicide. The point is, you need to be flexible so that in some cases I'm protecting, I'm providing, I'm sacrificing, but in other cases where it's called for, I'm allowing others to protect me, to provide for me, and to sacrifice for me. However, doing so pushes against very deeply ingrained ideas that we have about what men, and in particular, what fathers are supposed to be. And so asking for help for a father during the perinatal period is a major uphill climb for reasons that are not biologically based inherently. This is a lot about how we teach ourselves and how a lot of us will engage in a kind of gender policing that we're not quite aware of, but that ultimately contributes to problems with these fathers. The methodological issue, in a way, it sort of jumps off that 2013 JAMA article that Dr. Fisher pointed out, that once you factor in a masked male depressive presentation, that it goes from 1-to-2 ratio of males to females out in the community to 1-to-1. Well, that kind of large scale research has not been done in the perinatal period with fathers. The most recent one that I'm aware of is a 2017 study that looks at comorbidity of depression and anxiety. And it was a large sample of, say, like 3,500 Canadian fathers. And it showed that about 20% had comorbid anxiety and depressive symptoms at some point during the perinatal period, which basically gets to that 1 in 5 statistic. And so I think factoring in a more nuanced male sensitive presentation of depression is likely to get us to actually the prevalence is significantly higher than 10%. And this point about invisibility was addressed in that earlier slide. And Brett in the comments has been very bravely talking about his own experience as a parent with a child in the NICU and feeling traumatized and not included and invisible is a major contribution, not just to potentially acute stress or PTSD, but fathers who might be really gassed up about taking part in enacting that fatherhood role, but repeatedly, sometimes from systems, sometimes from partners, sometimes from other family members, that he's not that important, that he's not that central in it. And so the father kind of will naturally sort of step back or not be as involved. Fast forward a year or two, then he's got a partner that's saying, dude, step up. And I'm not in any way trying to, blame partners themselves. I'm more trying to take a more holistic ecological approach and ask the question, where are these specific people and systems and resources that are telling the dad from the very beginning, you are important. You are needed. You need to take care of yourself, but you also really need to be in there and engaged and involved as much as you can. And I'm here to tell you, they're few and far between with any kind of concreteness. And so when we look at, this final point, looking at the variety of mental health implications, be they intra-personal or interpersonal, taking a more systems approach that addresses the complexity of how these fathers experience and how they want their lives and how they want to show up in their new families, it involves moving past the sort of reductionistic, like bumper sticker approaches to here's what it means to be a father and a man. Next slide, please. So really quickly, realize I'm probably preaching to the converted here about the need to use evidence-based approaches. I say this because in working with men and fathers, we see a lot of men and fathers here in our clinic, and being able to sit down and do an initial evaluation that says, okay, here's my understanding of your strengths and areas of difficulties. Here is an initial provisional diagnostic picture, which then maps onto this treatment plan. And this treatment plan consists of these specific goals, which the evidence base suggests are likely to be helpful to you. And they can be psychosocial, they can be medication, a variety of different. But the point is, bonding first on the work and developing the relationship on, you're an expert and you're giving me things to do, which are tools and techniques and things to do between sessions, we get a very, very high return rate. It's much less like, well, we'll kind of wander around in the forest together and sort of see where you can do that. But I'm here to tell you that having that kind of plan and being able to say, we're using the research here goes a very, very long way. We have a very, very high return rate and engagement with our patients. So Dr. Fisher covered different screeners, and they're very important. The scores, do they indicate suicidality? Do they indicate a high level of depression and then implications for babies, the parents themselves, and so forth? From a clinical perspective, we'll also tend to use screeners as a jumping off point, at the beginning of a conversation. Like, hey, what was it like to fill that out? Any items that you want to sort of talk a little bit further about? And then, of course, there are the administrative points about how do we store this if it's a father and it's a pediatrician and we don't want to put that in the file. And so we touched on that, and that just varies a lot from site to site. And if you want a Q&A a bit more about it, modalities to consider go beyond just weekly one-on-one. Of course, there's the whole continuum of care, from fathers that get admitted for inpatient stays to PHPs to IOPs. But at our outpatient level, groups, men's groups that include some of these fathers tend to be very, very impactful. We teach expectant fathers classes here at the Center for Men's Excellence. And I find that more sort of preventative approach, where they come in and, yeah, you're learning about swaddling and soothing and burping and so forth with the infant mannequin dolls, but talking about their own mental health and keeping the relationship strong and planting that seed before they have their baby, I think goes a very long way towards having a sense of, wait, I'm important in this process. I need to keep myself healthy. Programmatic applications, basically, they're out there. There are a few really solid evidence-based approaches that have gone through randomized control trials. I'll say a little bit more about those, but if you want to do father engagement work, you don't have to start from scratch. There are programs out there that I strongly encourage you to consider. And if you don't consider doing father engagement programs, whatever your setting is, I encourage you to start. Next slide, please.
Yeah, and if we're transitioning to the next slide, I just want to point out that for moms in the same time frame, therapy tends to be very pragmatic, right? It's like you said, we're not wandering through the desert, talking about everything. We want parents to get well so they can be the best parents that they can. And so it's short-term, pragmatic, symptom relief, coping skills, getting them moving.
Yeah, agreed. Really quickly, I'm mindful of time. I wanted to show this slide because we use CBT and exposure, but also a lot of mindfulness-based approaches, including acceptance and commitment therapy. It's a modality that lends itself really nicely to working with parents of any gender, but in particular here fathers, because of the identity shift and the salience of values, which persist throughout the transition, but oftentimes the behavior and the manifestation of them looks different. So this is an exercise where we'll go through, and step one is let's elucidate the 10 areas of your life, these value domains that are important to you. Step two is how many hours a week that I'm awake do I spend in these? And then step three is to come up with what's my ideal. There is no objective ideal, it's completely subjective, but that's what's on the right. And we're not trying to get them to their ideal. We're trying to, on a daily basis, commit to valued action that is value congruent, that takes work. It takes work to do. Like, let's take this step. And there are reasons why I haven't taken it. So I just wanted to put a quick plug out there for folks to consider doing acceptance, commitment, identity, and values-based work. I also really like interpersonal psychotherapy because it's so relevant in terms of, you know, grief and loss and the identity that I had and role transitions and so forth. All right, next slide, please. This is a scale that my colleagues and I developed. It's the paternal involvement with infant scale. It's actually a 35-item scale that gets at fathers' sense of connection and involvement with their babies in different ways. We use it for research, obviously, but going back to my point about using screeners as a conversation starter, plenty of times in the middle of a session when I want to give this to a father and or to a couple and have them fill it out, I'll have him fill it out about himself. I'll have his partner fill it out about perceptions of him. And that can really lead to some very rich conversations about overlap and disconnect and so forth. And so quick plug to look at father's involvement as essential and now in a more evidence-based and concrete way. Next slide, please. So these are a series of resources put together. One, Jane Honigman, she's the founder of PSI. I wrote a book with her. She told me if I don't hype it every time I talk, she'll come down from Santa Barbara and rough me up. So if you see Jane, say, hey, now I saw Dan talk. He talked about the book. Don't harm him. Beyond that, I mentioned the Expectant Dads class we teach here. We're actually teaching a virtual one in several weeks. And so if you have expectant dads that you think might be a fit, you can check it out on our website. They can register there. Folks probably know about Postpartum Support International. I do a monthly dad's chat that folks can call in. It's just an old school phone call. It's pretty anonymous. It's a really nice way for fathers who are in it with PMADs and or partners to get a sense of community. It's a Texas outfit, Hand to Hold. Dope Black Dads is exactly what it sounds like. Very, very active on both on Facebook and on their website. Man Therapy is kind of like a guy-centric, like you know, Ron Swanson meets I don't know, Freud or something. But it's kind of like a guy-centric way to approach therapy. And then Dad is the father-centric chunk. The National Fatherhood Initiative has a lot of resources about programmatic applications. And so if you want to look at fatherhood programming, consider going to fatherhood.org. And then, of course, the MMHLA has a ton of resources. So go there. We have a brilliant new fact sheet that I encourage everyone to memorize. So. All right.
Awesome. Well, thank you so much, Dr. Danny. We have just quick policy recommendations. In fact, I think we're just going to skip right over this because we're just about out of time. These slides are included in your handouts, and we'll be sending all of this. I just want to go through just a couple of things. Congress is introduced some legislation. We've got some additional policy recommendations. Dr. Sheehan talked about those a little bit earlier on. But let's go to the final slide so we can say thank you to all of our speakers. Right. So again, after this, we will send out an email that includes all of this information, including a link to MMHLA's resource page where we have all of these resources listed, including there's some podcasts. I saw a question in there about podcasts, books, all the resources that Danny went through. We have been trying to answer the questions as we've been going along. I hope we got to yours. We also had asked for questions in advance, and we tried to work in answer those questions during the presentation. We've got a very short poll. One or two questions. Was this webinar helpful? We ask that you fill that out, whether yes, somewhat, or no. This gives us information so that we can continue to provide excellent resources and information to all of you, our audience. Thank you. We'll share emails, right? I see Danny was putting his email in the chat. We are so grateful again to our terrific speakers. Please give us, help me with a big round of applause for our dream team of dads with David, Danny, and Sheehan. Your children are so lucky to have you in their lives, and we are lucky to have you as part of this team today, and all the dads out there that you're helping. Thank you. We're just so grateful that we're talking about these issues, not only for moms, but for dads, for the whole family. And mental health is becoming, it's still stigma, but again, the fact that we even had this webinar and that we had over 500 people register and almost 300 people participate, that's huge. So thank you again to our audience, everybody who took time from your busy days to be here, as well as my great colleagues at MMHLA, Mia Hempstead and Mara Child and Allison Meisler, who is on this call. We really appreciate all that you do. So thanks again. Keep an eye out from an email from all of us with all of the follow-up information. Thanks, everybody. Have a great rest of the day.